This case involves a 65-year-old male who previously underwent secondary lens implantation with a CM-T Flex IOL, resulting in a fractured haptic that led to dislocation. A subsequent surgical attempt to reposition the lens not only failed but caused further damage to the already compromised haptic. The patient was eventually referred for IOL explantation and secondary lens insertion. However, this case presented a unique challenge. The remaining haptic was stably fixated, and explantation risked inducing further trauma to the intraocular structures. So instead, an alternative approach was done. A gauge 25 needle was inserted 2 mm from the limbus at approximately 2 o'clock. The needle was carefully maneuvered to gently lift the dislocated lens. After a few failed attempts, the needle position was adjusted to the 6 o'clock position. Successful levitation of the lens was achieved, after which a spatula was used to center it. And a chopper was employed to manipulate the fractured haptic anterior to the iris while avoiding trauma to the surrounding structures. Initial markings were made 2 mm from the limbus. Secondary markings were made 1 mm on either side of the initial mark. Additional markings were placed 2 mm from the secondary marks. Now these marks are made to guide the needle's scleral tunnel route. Following the markings, a gauge 25 needle was tunneled through the sclera, passing through the lens eyelet from underneath and exiting anterior to the lens. This is how it looks in animation. A 6/0 proline suture was threaded through the needle and eventually pulled out through the tunnel. Now the same procedure was repeated on the adjacent side, with the needle tunneled through the sclera and positioned anterior to the lens. And again, this is how it looks in animation. The other end of the proline was threaded through the needle and eventually pulled out through the tunnel. The lens was gently pushed under the iris into its proper position using a chopper. And the proline sutures were pulled taut, anchoring the dislocated side of the lens to the sclera. The suture ends were trimmed to approximately 2 mm from the base since we used a gauge 25 needle, and flanged using low-temp cautery. And yes, a gauge 25 needle works just fine. Important thing is the flange should be big enough not to slip through the tunnel and small enough to be buried into the scleral tunnel without eroding through the conjunctiva. This approach successfully centered and anchored the lens, restoring its proper position. This technique highlights an alternative to IOL explantation, reducing the risk of trauma to intraocular structures while achieving stable fixation. This is a viable solution for lens dislocation from a T-haptic fracture, especially in CM-T Flex IOL.